Honestly, we will be using Menti to facilitate that. Right, the recording has begun. Okay, I'm excited to announce our topic for today, which is low threshold MOUD, or medications for opioid use disorder, expanding access where people are. Next slide. So a little bit about the flow of today. I will introduce our speaker. We'll have a didactic presentation from our speaker today, and then we'll move into that case presentation, questions and answers, and then some closing remarks. Next slide. So I get the pleasure of introducing Dr. Cooper, who has spent over 2 decades providing harm reduction services. He's been with Meharry for 10 years, during which time he founded the Meharry Harm Reduction Center. He's also presented his work nationally and internationally, and we've had many chances to partner with him in the past. Thank you for having us today, Dr. Cooper. Next slide. All right, and we will get into the presentation. So I will now be turning it over to you, Dr. Cooper.
All right. Thank you, Amber. I'm just setting a little timer for myself so I don't get too chatty. So I'm excited to talk to you guys about this today. Just as a little bit of background, the Harm Reduction Center at Meharry includes our syringe exchange program, as well as our MOUD clinic, which is really kind of linked to that in a lot of ways. And so I'm excited to talk to you about how we approach MOUD from a harm reduction kind of perspective. So let's move on to the next one. All right, so today we're going to do a few things. One, will talk about what low threshold MOUD is and what are the principles that sort of guide it, which is going to be really important because depending upon your context, you may not be able to do all this. I know from working in Tennessee, which you guys do, there's a lot of these things that are going to be hard to pull off, but it's kind of how can you get as close to it as you can, really is a lot of what we're trying to do. We'll also talk about some strategies to reduce barriers to engagement, which I think low threshold care, that's its real strong points. We'll talk about that. We'll talk about some of the challenges and opportunities across diverse settings, just kind of a focus on my perspective from being in Tennessee, because I think that's relevant to you guys because we're all here together. And then finally, we'll turn it over and do a little case discussion. So why low threshold MOUD? And I've just been saying this, but I think this is a crowd that probably knows this, but medication for opioid use disorder. Why would we want to do that? I think one is there's 2 big overarching reasons for me. One is I think it realigns our priorities as it relates to clients. What are we doing when we're trying to help clients at all? I think we kind of, especially in the drug use space, but probably in other spaces too, just prioritizing the first big priority, which is how do you keep people alive, and then sort of doing a hierarchy down from there. And I think low threshold models of care do that in a better way than what you oftentimes see in more high threshold kind of models. And the second one is just putting patients back in the driver's seat. I mean, with almost any other disorder other than substance use disorder, there's sort of a hand-in-hand partnership about how do you deal with the medical problems that you have, and patients make lots of decisions, some of which we don't agree with. But in substance use, sometimes care gets used as sort of a leverage point to get people to do the sort of things that you want to do. And I think the low threshold models kind of move us away from that, which I feel like people should be in charge of their own healthcare. So those are the 2 big overarching reasons, but then a couple of other things is one, traditional MOUD doesn't work for everybody. The abstinence expectation, one of the things that I always think is, why do people not go to treatment? Because they're not ready to stop using drugs. And so if that's the case, how can we set up a situation where we can keep people from experiencing some of those consequences of use and get the care that they need, even if maybe they're not ready for that? Other things that play into that, the strict appointments, frequent labs, those are things oftentimes that set up a situation that's unequal for people that receive our care. People that have more barriers in their personal social life are going to have a harder time going to care in those traditional models. What else do we know about this? There's a lot of dropout in higher threshold models, more requirements that people have to live up to that oftentimes they may not be able to, so you lose people. Another one, which I already mentioned, and when I'm talking about inequity here, really, a lot of this has more to do, although it may overlap with gender, or race, or ethnicity, a lot of what we're talking about in terms of inequity here is that people who have fewer resources have a harder time meeting up with the expectations. And then finally, the outcome of that is we get people who don't get care. And then finally, low threshold care, it does remove a lot of those barriers and it maximizes a lot of our engagement. So can we move on to the next one? So what are the principles? These five, and I think you could probably say more about it, but given the time constraints, we're kind of sticking to the overarching. But we're really, if you think about it, all we're trying to do is make care the most accessible in terms of initial engagement and the most likely to keep patients retained. So what do you do to do that? One, we all know if we've worked with folks that have a drug use disorder or that even use drugs, motivation is sort of it's a fluent sort of thing, right? If a person comes in and they want to get care and we can't give them to them that day, that next day may not be the day that they want care anymore. So same day initiation is critical. And this kind of feeds off of that because as the drug supply has changed, induction has become a little bit more difficult. And while people do call me Dr. Cooper, I'm not the useful kind of doctor, so I can't tell you how you would actually do this except for to give you sort of the broad strokes. But one of the things that's really been a shift is we've gotten into sort of the era of fentanyl, and it was already a problem with methadone, was how do you perform the induction in such a way that's going to keep people away from getting withdrawals and still be able to engage them in care that day? Because, I mean, one of the things I think about is like with naltrexone, if you have to get somebody to come off drugs for 7 to 14 days in order to go on to the treatment, that's a real problem, right? We've already violated our first principle because we're not going to be able to do same day initiation, which all those motivational factors come into there. So micro induction is kind of where we're headed right now in order to support that first principle. Another one is no requirement for counseling or abstinence. And when you talk about a low threshold model in the most pure sense, counseling wouldn't be a requirement, but your context may make that a little bit different. So we'll talk a little bit about how we finesse some of this because Tennessee is not a state where that could be pulled off. And no requirement for counseling for abstinence. Another one of those things, if our highest priority is to keep people from overdosing, do we really want to utilize a person's access to care as a way to kind of force that abstinence, or do we want to keep them in care and over time kind of move them towards a recovery or at least just make their lives safer? The fourth one there, tolerating missed visits and ongoing use. We said high threshold models oftentimes result in some inequity. And one of the places where that comes is if you don't have a car. One of the things we're facing right now is where you've got a shortage of bus passes and you guys have all been outside. It's ridiculously hot, right? Our patients that can walk in the fall, they really can't walk to care in the summer. So if you function from a high threshold model and your patients aren't showing up, sometimes that's a reason to discontinue care. In a low threshold model, we're going to work out ways to kind of get the patient there. We're going to be more flexible in how we work with them. And then finally, we should have multiple entry points. Commissioner Williams and I have talked about this for years, but it was her term, was the no wrong door, right? Anywhere you go, you should be able to get the sort of help that you need. So next. All right, so what do we know about low threshold buprenorphine? I'm going to give you just some overview, and then I'll talk about a few studies, but it's related to improved retention and engagement, as you might imagine, right? If you can go in and start your care on that same day, it's going to be easier to engage you. If you have less sort of barriers to being retained, like making every appointment or, not using other drugs, then it also makes it easier for you to be retained across the long haul. It's also associated with reductions in overdose death. It also gives us a space where we can do all kinds of other things for patients. You know, once we get people into care, they may or may not become interested in recovery, but when they come every month to get their buprenorphine, you can have all sorts of conversations with them. You can do screenings for HIV and hepatitis. You can build in things around sexually transmitted infections. So it just creates an environment where you can improve people's health more broadly. And then finally, it expands equity. And when I'm talking about equity here, a lot of that is just access to resources, right? I will say a couple things that I've heard in terms of like criticisms of low threshold care is it really appropriate for more complex sorts of presentations? I can't speak to all the complexities that you may encounter with a patient that has an opioid use disorder, but I can say in our own work, we just published a study about the impact of stimulant use on retention and care, which that's another thing I should have brought up earlier is when you think about a low threshold model, certainly you'd love to see your clients use less frequently, right? Or not use other drugs. That would be great. But a lot of times they don't. And if our real measure is keeping people, if our real goal is keeping people safe, having people not die, because all of us are aware of this overdose epidemic, then retention becomes really one of the most important variables we have in terms of looking at outcomes because people are protected to a certain degree when they are on buprenorphine. So we just look to see, okay, if we have folks who are coming in and they're also using methamphetamine primarily, they may also be using cocaine. Can we still retain those people in care even in this low threshold model? And what we found was yes, indeed we can. Not only can we, the retention rates for folks who were also using stimulants were just a smidge higher than the folks who weren't, not statistically different, but a little bit. What else? You know, in terms of just treatment outcomes overall, if you check out the anchor model that's located in Washington, they found that retention rates are better in low threshold models than in high threshold models. Another interesting study, although is from Jakubowski. I may be saying that wrong, but I really love this. I really love her work. She's published some things on low threshold outcomes, but she also published an article that was really influential on us that was just sort of describing the low threshold model. But they again found retention rates are very similar to high threshold models. And finally, one area where we don't have as much research yet, and there's a lot of reasons for that, I've done some work in this space too, was that working with justice involved patients was a little more difficult. Retention rates weren't quite so good among folks who were justice involved. And so I think there's a lot more work to be done in that area. But one thing that kind of strikes me about that is there's a big mismatch in philosophies between criminal justice and low threshold harm reduction sorts of models. But it's something that we can work out over time. Sometimes that is successful. So next. So what are the strategies here? I mean, I already mentioned microinduction, and again, I'm not a medical doctor, so I'm not going to try and explain the minute details of this, but there are a few models for microinduction that have become more important as fentanyl has become sort of the dominating drug in the drug supply that we have. And there's a few different ways. I think the Bernese model was the first one that really kind of became common. And in there, what you're doing is you have an overlap of the full agonist, so probably fentanyl or methadone, because usually this gets applied with those drugs that have a longer half-life, but that you would overlap the use of buprenorphine with those illicit drugs or the full agonist if you were wanting to shift somebody from methadone to buprenorphine. There's also rapid microdosing models where there you're just doing smaller doses across a 5 day period, 1 to 5 day period. And then now I think the sort of blanket term is like low dose buprenorphine initiation, because I think a lot of folks were like microdosing. What are you talking about? Right? We hear about a lot of microdosing. It's not that kind of microdosing. So making that a part of your normal practice is critical. Extending take homes when stable I'm not working in a methadone clinic. I'm working we operate a buprenorphine clinic, but getting folks to that point where they can have a month between sessions is huge for people because you think about, I mean, methadone, could you imagine having to go to a doctor's appointment every single day of your life, right? It's just untenable. It's actually becomes a barrier at some point. Similarly with buprenorphine, could you go to one every week? I couldn't. I can barely get myself there in 6 months. So getting to those take homes soon. Another bridge scripts from the emergency department, outreach, syringe service programs. Those are kind of early versions. I think before we were even talking about low threshold MOUD, that was something that was being done, right? Medication was being given first, and people were referred out to counseling after. Sorry about that. Phone's hooked to my computer. And then finally, having some flexibility with co-use, right? There's definitely some dangers associated with benzos, gabapentin, those sorts of things that you would combine with buprenorphine. Same with stimulants, maybe a little. It's not that they're going to have sort of a compounded effect, but being flexible with that, because if the thing that pushes the patient out of treatment is going to be that they can't stay on their benzodiazepine prescription, we've got to look at other ways to get around that, right? Because then we've got another person who's completely out there with no protection that they would get from the drugs that we could provide them. So next. All right. So where does this actually happen? There's SSP-based starts. That's one of the things that we're working on right now. We just got permission to do this from the college, so we're going to be doing that is like taking the care to where patients are. That has a huge impact and it reduces the threshold greatly. Kind of similarly, street medicine vans, shelter-based clinics, places where you're going to find these folks where they stay. Emergency department partnerships are huge in this. Again, that when you go back to that first day initiation, catching people when they're in that situation of being in the emergency department is completely different than catching them the day after, And there's other things we could add in there. I mean, there's criminal justice spaces are a biggie, one that I think a lot of us are working on. I'm working on doing some of that in Cheatham County right now, but it's slow moving, I'll tell you that much. But that's where we want to see this happen. In essence, when you think about the implementation and practice, you just want to get the care as close to the patients as you can so you can reduce the barriers to entry. So next. So what are some of our problems here that might kind of hold us back from this? What are some of our barriers? I think there's definitely some regulatory limits. I've mentioned this a couple of times. I mean, if you're a provider that's receiving money from the state, you can't forego counseling. So what can you do with that? There's limit on co-prescribing. There's limits on the number of milligrams that you can give to a patient in their medication. Methadone, of course, has tons of stipulations that you have to go through. Again, I'll just give you a quick example here of one way that you can work around this. We provide counseling to all of our patients, but instead of centering the counseling around the urine drug screen, right, which a lot of times is what happens, you get the drug screen, that's the thing you talk about, is focusing more on the patient's quality of life, right? Why am I stopping using drugs in the first place? Why am I getting on medication for opioid use in the first place? Because I want a higher quality of life. So to that degree, I think it takes a lot of the sting out of counseling when people don't want it. Another thing is, work with the patient on what they want to work on. I would say that probably about 60% of the patients that we have in our clinic are really engaged in recovery. That's what they're trying to do, right? But we've got another 40 that just want to be on the medication because they don't want to be exposed to overdose. And a lot of those 60 came in just like the 40, right? And as they stay with us, a lot of times they make that decision organically. Sometimes they don't, and that's okay too. So diversion concerns, with this, I think we got to be really careful because I think people have this notion that like diversion is somebody coming into the MOUD clinic, getting all the buprenorphine, going out on the street and selling it. Nobody really wants to use buprenorphine. Talk to your own patients about it. If you haven't asked them, they'll tell you, when do they get buprenorphine on the streets? I don't want to use today. I can't find anything else. you know? So there's that. How likely is it that patients are actually doing that? What we find is that diversion is usually sort of utilitarian, you know? I've got to go to my appointment, I've got to get across town. My friend, if I give him one of my tabs, he may drive me, right? If I could sell one to someone, I might be able to get gas or a bus pass. So thinking about diversion in sort of a more nuanced way, right? It's not always that somebody's just trying to pull the wool over your eyes. A lot of times it's meeting a need. So, what else? Stigma, it still exists. It does too, I'm sure. I can't tell you how often I'm in conversation when I hear people talk about dirty and clean or whatever. Just, working with your staff so that they can start to work on some of their own biases related to substance use, because it's in the air that we breathe, so all of us get exposed to it. Just keeping it out of our work. Funding and sustainability, certainly a challenge for all of us, becoming more challenging every day, I think. But there is funding out there. You can get insurance reimbursements for this. There's ways to kind of support the kind of care that you want to provide, that you can move away from some of the limitations that come with some funding that you get. And then finally, let's move to the next one. So roles. I talked a little bit about the braided funding. For our clinic to function and for us to be able to do lots of other things, we have grant funding, we have insurance funding, we have contractual funding. All of that funding kind of gets worked back around to support our different sorts of programs. It also, we use different funding streams for different patients based on the needs and maybe some barriers that may come or strings that may come attached with certain funding streams. So looking to diversify in that area, doing a lot of task shifting, figuring out ways to keep your prescribers from doing jobs that, so keeping everybody practicing at the top of their license. So you can move people into a lot of different situations, using physicians, NPs, and using NPs and PAs as the prescriber, one way. Using your nurses for critical patient education, follow-up, even using RNs as sort of an extender can be helpful here. Using your SSP staff to help with screening initially before you even go into the SSP. So just trying to make sure that whenever your folks go out, that everyone's practicing at the top of their license or certification, whatever that may be. If you do find diversion, I think I touched on this, dealing with it without punishment, because like I said, a lot of times it's just a necessity for them to get the care that they need. And then finally, building up those partnerships, because people need a space to come to you and you want to create as many doors to care as you can. I think this is our last one. Yep.
Thank you, Dr. Cooper.
Yes, thank
Really
you.
appreciate that. As always, we have a Menti where you can ask questions anonymously. You're also always able to unmute and ask those questions or raise your hand and we'll call on you. You can join the Mentimeter by scanning that QR code with your smartphone, or you can use a link that Allie just placed in the chat, or you can go to menti.com and then enter in the digit code 77613407. Next slide. And that is now open. So as I mentioned, you can utilize the Menti to ask questions of Dr. Cooper, or you can always raise your hand or unmute. While we're waiting, because it sometimes takes people time to type, there was one question earlier that Dr. Troxler answered, but we'll ask it to you too, in case you have also anything to add. Is the goal of microinduction to reduce withdrawal?
Yes, I think definitely to reduce the chances of precipitous withdrawal, but also to kind of, dependent upon the model, the Burmese model is probably the best example, is that you're wanting to make that shift from illicit drugs to buprenorphine very smooth, because people aren't going to have the same sort of euphoric effect that they have when they're on heroin or fentanyl, say. And so making that transition as smooth as you can, avoiding any sort of withdrawal symptoms to the best of your ability, as something that's just going to keep your patient as engaged. Because one thing I will say, this has become much less common, but it's still sort of the thing. If you talk to somebody and they say, oh, I can't be on buprenorphine because it makes me totally sick. I think I might be allergic to it. It's almost always because of the way that it was prescribed when we really go back and look at it. So being really cautious with that, because yes, indeed, at the patient to provider level, it does reduce the chances of precipitous withdrawal. But then if you have somebody come out of the interaction and think, well, I never want to take buprenorphine again, it makes me sick. Well, then that's created a whole nother problem.
I'll just add to that as well with the that micro-induction type of thing. We've not had good luck outpatient wise making it that transition like by micro-induction. I was about to say micro-dosing, by doing a micro-induction, because they kind of ride that, like, I don't feel so good, so I take some more, but I don't feel so, like, it's hard. They know what will make them feel better. And so we've actually done some of these that have taken several months to get people fully transitioned over. So it can be quite a labor of love, depending on the individual, getting it done. These models actually work the best in a controlled environment. And we've done them inpatient when we have patients at the hospital we're consulted on. But the California Bridge program has, which is a wonderful resource for the work they're doing with opioid use disorder and treatment in California out of their ERs. They have a model for what's called a macro, I do that all the time, macro induction, where the way you overcome precipitated withdrawal is to keep plying on the buprenorphine. So you just kind of like, I don't know, I'm kind of a bulldozer personality anyway, so I just bulldoze that stuff out of there. You're uncomfortable, but for a very shorter period of time. We give medicines to kind of help with the discomfort, but the truth of it is what's going to treat that precipitated withdrawal is more buprenorphine, because it'll just shove off all the opioids, fill in the receptors with the buprenorphine, and you're fine. You can actually get those kinds of inductions done in like a day. Again, inpatient is better, but if you've got a room in your office, you could do it in your office as well.
That is great. Oh, thanks for the link. All right. So the TBI was initially heavily opposed to the recent change in legislation that increased how many patients NPAs can have and MTs can supervise because of diversion. How can we help decrease diversion? Again, I think I'll be interested to hear what other people have to say about this, but we really don't get a lot of people that are coming and when I say not a lot, I mean, in the 8 years that we've been in an operation, maybe it's happened once or twice. It's just very, very infrequent because, as access to buprenorphine has become, and this is not just me saying this, there's a few studies looking at this. States that have more access to buprenorphine have less diversion. So getting more prescribers out there just means more people are going to be able to get to it, and the street value of it is going to go down. And typically when you do see diversion, when I say we've only seen one or two people that divert, I'm talking about people that came there and just wanted to get the prescription so that they could take it someplace else. Do we see some minor diversions, like people coming out with a few shorter strips or pills at the end of the month? Absolutely, that happens. But again, I think a lot of that has to do with those equality of access sorts of issues. If it is a commodity and people can trade it to somebody, people can sell it for a little bit of money to get where they need to go or to get food or whatever the case may be. And that's the more common sort of diversion that we see. I don't know if that totally answers that question, but I think part of my answer is I don't worry about it as much, but I know that the TBI and law enforcement definitely does worry about it. It's kind of walking that sort of line, right? We want to put in some parameters, but at the same time, recognize how big of an issue this actually is. Yeah. Absolutely. We hear that a lot. One of the things we looked at when we did the study of stimulant use was that we asked people, had you ever taken buprenorphine illicitly? And we found that folks who'd taken buprenorphine illicitly on the street were more likely to be retained in buprenorphine care, at least in our clinic. We haven't written it up yet, but it's really kind of an interesting finding because your clients are doing this.
And any other questions, or SMEs if you want to weigh in on anything else? If not, we can move over to our case study where there will be more robust conversations about this topic. Okay. So since we're moving into the case study, we are going to end the recording at this time. We will also still